So let's start with steroid medications in general. First of all, I'm a big advocate for inhaled corticosteroids, mainly because I don't want my uh, pediatric asthma patients to need oral corticosteroids, which is how they are typically managed when they develop an exacerbation or a flare up, particularly if you go to an emergency room or an urgent care and somebody sees asthma on the chart, you're almost certain to walk out of there with a prescription for oral corticosteroids. So why do I make that distinction? Oral corticosteroids are the ones that really do have adverse effects, particularly if taken in the long term on a daily or even every other day basis. They'll have behavioral side effects. They'll stimulate appetite and therefore cause weight gain. And they can have those are the commonest ones in pediatrics. Some of the behavioral ones are just unbearable. I mean, the child's behavior becomes uncontrollable. So and I hear about this from parents, so I try and avoid those as much as possible. Now, there's a common misconception out there that, oh, you can have 3 days of an oral steroid or 5 days of an oral steroid, and it's not going to have any significant side effects. I've just described the short-term side effects that you'll experience in the few days that your child receives them. There is a long-term price to pay as well. And this was shown in the Childhood Asthma Management Program, or CAMP study, that was published in the late 90s in the New England Journal. They actually took school-age children, gave some an inhaled steroid, gave some nadocromil, which is similar to an old drug called cromolyn, and the third group got placebo. And it was a 5-year study, and they looked at exacerbation rates, like rates of flare up, and how many times the child required a short course of oral corticosteroids. At 5 years, they published the first findings, or after 5 years, that showed up in the late 90s, and it pretty much set the standard that children with asthma should be on a daily inhaled corticosteroid therapy. They were very clever in their study design, and they actually recalled many of these children. And I think the original number was 800 or 900 across the country, including Toronto, Canada. They called them back as in late adolescence, young adulthood, and they looked at final adult height and bone mineral density. And the two findings in the long-term follow-up, and that was published in, I think, Pediatrics about 10 or 12 years ago, showed that the more times a child received a 5-day course of oral corticosteroids, such as prednisone, prednisolone, Orapred, Pediapred, dexamethasone, the lower was their bone mineral density in early adulthood. It's not to say they had osteoporosis or were at increased fracture risk, but it's just to say that there is a long-term cost to this approach. Secondly, in the children on daily inhaled corticosteroid, they looked at their final adult height. And the study investigators had a pretty good idea where the child should end up once they ceased growing based on mid-parental height. And the estimated cost on their final achieved adult height in this inhaled steroid treated group was about 1.2 centimeters in final adult height. So what does that translate into? Somewhere around 3/8 to half an inch. So as a parent, do you want your child to be 5'10" instead of 5'10¾", 10.5, or do you want your child to avoid urgent care visits and oral corticosteroid? In my mind, the answer is pretty obvious. And so is the choice. So that's why I'm a big advocate for daily inhaled corticosteroid. Incidentally, the nadocromil treated group had outcomes no different than the placebo treated group. So in other words, if you believe in nadocromil, it's misplaced belief, because a very large, well-done study showed that it was no better than placebo. One other piece of information about short courses of oral corticosteroids. There was a study published out of Taiwan published maybe a couple of years ago in JAMA Pediatrics, and they looked countries that have socialized medicine, particularly the Northern European ones. Finland is great. Taiwan's another example, not Northern European. Small population where everybody's drug prescriptions can be tracked. So what this Taiwan study did is look at prescriptions for oral corticosteroids and subsequent health events in the 30 days after the child was prescribed the medication. They couldn't verify whether the child actually took it. And what they found was there were higher rates of subsequent GI bleeding and severe infections defined as sepsis in the children who were treated with short courses of oral corticosteroids. Now, the short course of oral corticosteroids in Taiwan are longer than those typically given in North America, for example, and even in Europe, in my experience when I practiced in the UK. There, they would administer 7 to 14 days, whereas here in North America, we pretty much confine it to 3 days, maybe 5 days. In my personal opinion, should be no more than 7 days at a time. So we don't use them for as long as they were done in the Taiwan study. But just so parents are aware, and most doctors aren't aware of this, that we just don't know whether a 5-day course of oral corticosteroid is truly harmless, even in the short term. Because we've never done such a study in North America. We don't have the tools to do it. Now, so that's why I avoid oral corticosteroids. Let's talk about inhaled corticosteroids. There are several out in the market: fluticasone, budesonide, mometasone, cyclosinide, and an old one called beclomethasone. They vary in potency. And the way they measure potency of these inhaled corticosteroids is a very bizarre way. But they differ in potency, so you cannot compare them microgram for microgram or milligram per milligram. The dose ranging studies are basically done by assessing clinical outcome. What was the improvement in lung function? What was the improvement in symptoms for X number of micrograms of drug A versus drug B? And there are comparison charts showing the relative potency of all these inhaled corticosteroids. And they all have some unique characteristics. So there are some attributes of these medications that you can apply across the board, a so-called class effect. But for some, certain events or outcomes may be more common because of the particular inhaled corticosteroid under study. Now, then we have to talk about delivery system. Pulmicort, which is budesonide, is a good drug. In fact, the CAMP study used Pulmicort. It's not quite as potent microgram for microgram as drugs like fluticasone or mometasone, but you can get the equivalent treatment benefit just by upping the dose. So delivery system becomes very important with Pulmicort. It's available as a little nebule that you crack open, put in your compressor, and then your infant or young child will inhale the mist for whatever number of minutes it takes to nebulize the entire solution that's in the nebulizer. Very simple, if not time-consuming in concept. However, when you compare how much of the drug actually reaches the lower airways, like into the lungs where they need to go to be active, that wet nebulization is not a very efficient delivery system. And therefore, I see a lot of kids, because I'm a pediatric pulmonologist and I get the more challenging or less responsive patients referred to me. I will typically switch a child who's on nebulized inhaled steroid to a puffer with a spacer, because what studies showed, and these are in the early 90s, probably a lot of today's docs aren't aware of these studies. They're not old men like me or old women. You get better drug delivery from a puffer with a spacer that's done properly than you do with the wet nebulized form. Now, there are newer compressors out in the market, newer wet nebulized delivery systems that, to my knowledge, haven't been studied as well as they were 30 years ago. So I generally don't use much wet nebulization for an inhaled steroid. Parents have told me, and I believe them, that when it comes to the rescue medication, the bronchodilator, the albuterol or Xopenex, their child does better with the wet nebulized form. I have no trouble, no qualm with that, because you don't need much of that class of medications into your lungs to get the desired effect. You do want your inhaled steroid to get down there, though, because an ounce of prevention is worth a pound of cure. Now, when we go to modern treatment options, today's treatment options and all the controversy swirling about with generics and all that, you know, a lot of these pharmaco care plans are predicated on what an average adult would use. They do not take into account the difference in administration in a 1-year-old versus a 5-year-old. And I would go out on a limb to say that from the FDA point of view, once you're 12 or older, you're considered equivalent to an adult. At least a lot of the drugs get approved for 12 and up. So the 12 to 17-year-olds are lumped in with 18 and over. So 12 and up, you can use the so-called dry powder devices. And many of these pharmacologic plans say your preferred choice is a dry powder device. Well, you know, a child for sure under 5 cannot use it. I would even be suspicious about using it in a 10-year-old unless we could demonstrate that technique was basically spot on. So I don't even waste my time with dry powder devices under 12 years old. They're simpler to use because you do not need the spacer. You do not need that clear plastic chamber between the puffer and your lips, but they're not for everybody. So this is why parents often think, well, drug A versus drug B, but it's not so much the drug as it is the delivery system that determines the outcome, the success of therapy, if that's your benchmark. So right now, there's a big problem with Flovent, and that GlaxoSmithKline stopped marketing it. They didn't stop making it. They, in fact, are making it, and another company is putting their label on it. Insurance companies have been slow to recognize these new generics, and so in my clinic, it's a crapshoot. I tell my nurses, we'll use whatever one is most likely to be accepted. And honestly, I just had 3 emails this morning in my inbox about that. It's a constantly changing landscape. So I think there's been a lot of press about this. In fact, Bernie Sanders is supposed to be striking a congressional committee to look at the outrageous costs of asthma puffers in the U.S. So bottom line is you got to get the right drug in the right dose with the proper delivery system. And then you got to get the child to take it. And I'll even include adults in here because we know from marketing studies that the refill rates for inhaled corticosteroids is of the order of 35%. So we know that patients don't take them typically as prescribed. The FDA finally approved, I think as recently as last year, the so-called SMART therapy. SMART is an acronym for single, maintenance, and reliever therapy. And it's predicated on combining an inhaled corticosteroid with a long-acting bronchodilator into a single puffer. Now, there's at least 3 of them out on the market. Actually, there's more now. What am I saying? But there's several of them out on the market. It's important to understand that some of them can be used in SMART therapy and some cannot be used in SMART therapy. And the distinction or the difference between them is you have to choose the combination product that has the right bronchodilator, the right long-acting bronchodilator. There's 2 of them out on the market. One is called formoterol, the other is called salmeterol. I've used them both. I like them both, to tell you the truth. Salmeterol has a slow onset of action. So if you take it, you will not experience relief in minutes. Whereas formoterol, not only is it long acting, but it's also rapid onset. So you will experience relief in minutes. So the thinking behind this SMART treatment approach is we know patients don't take their medications as prescribed. It's human nature. When they reach for their reliever medication, is there a way to ensure that they're also getting their preventer medication? So when they reach for their long-acting bronchodilator that's going to help them in minutes, are they also going to get their preventer in the form of an inhaled corticosteroid? And you get that with SMART therapy. And what the studies have shown is that in mild asthmatics, I would not use SMART therapy in moderate or severe asthmatics. But in mild asthmatics, you can have as good symptom control, but with a lower total daily dose of inhaled corticosteroid, because on a good day, this person will not take their puffer at all. And on a bad day, they can take it up to 4 times a day. Some would say 6 times a day in older children, in adolescents. But that's not yet standard of care, let's say. So it's a lot to digest. It's a huge field. It's very complicated. And a lot of the misconceptions or a lot of the opinions that I hear from parents are due to misconceptions about which drug, which delivery system, and how it's used.